Welcome to today's discussion where we will be talking about the pharmacotherapy of select gastrointestinal disorders. Now this lecture is not all-encompassing, but it will focus on some of the major disorders that you'll see in primary care and less so on some of the more GI specialty disorders. So with that, let's get started. As with other lectures in this course, we will not be spending extensive time reviewing pathophysiology of the disease states that we're discussing unless it directly relates to the mechanism of action of the medication. And by the end of this discussion, it's my hope that you understand the pharmacology of the agents that we use to treat constipation, diarrhea, gastroesophageal reflux disease, peptic ulcer disease, and irritable bowel syndrome. The first group of medications that we're going to discuss in this lecture are those used to treat constipation and diarrhea. And one thing to realize when patients come to you complaining of these is that oftentimes they've tried over-the-counter preparations at home first. So you really need to assess the duration of the constipation and diarrhea and what they've tried prior before coming to your office. So with that little caveat, let's get started in discussing the specific medications. The objective definition of constipation is having a bowel movement less than 3 times per week. And as you see here, I've listed for you some of the multiple causes of constipation, but since we're a pharmacotherapy course, I'm going to focus on that last bullet point that says screen medication profile for new offenders. I think it's important that when a patient presents to you with constipation, you take a look at their medication regimen and see if any of the medications that they are currently on could be contributing to the problem. Some examples would be a new opiate medication starting for pain that slows the gastric motility and therefore can lead to some constipation, as well as any medications that have anticholinergic properties. Or if they were recently started on a diuretic, which could cause a little bit of dehydration in some patients, leading to less water within the stool and thus constipation. So an important point for this class is before you decide to treat the constipation with a medication, make sure it's not one of their current medications causing the constipation. The medications that we'll be talking about that you can use to treat the patient's constipation include the bulking agents, the stool softeners and stimulant agents, oftentimes those are in combination with one another, the saline laxatives, osmolar agents, as well as enemas used to treat constipation. So when would you use a bulking agent to treat a patient's constipation? Well, these agents are indicated for the treatment of chronic atonic or spastic constipation or constipation associated with rectal disorders as well as irritable bowel syndrome. So if your patient meets any of these criteria, a bulking agent would be an agent of choice to use. When you think of the bulking agents, basically think fiber because that's what these agents are. I've listed a couple of them here for you like psyllium or methylcellulose or even bran cereal is strong enough for some patients. These agents do just what their names state. They bulk up the stool. They're not systemically absorbed. The fiber derivatives in these agents absorb the water and results in that increased moisture content of the stool, and that then stimulates the peristalsis and reduces transit time. The typical onset for the bulking agents is about 12 to 24 hours. However, it's important that you counsel your patient that it may take 3 or 4 days of scheduled regular use to see the full effect of these agents. So if they're expecting to feel 100% better with the first dose, that's probably an unrealistic expectation with these agents. But if they're not feeling better after, say, 5 days or so, it may be time for them to come back and see you or adjust the dose of the bulking agent. It's an important point to remember that these should not be used in obstructed or impacted patients for the obvious reason that if they're obstructed and you bulk up the stool even more, you're going to worsen that obstruction or impaction. So you want to make sure to rule that out before these agents are used. and they should be used in caution with elderly patients. Sometimes elderly patients are less likely to get adequate fluid intake, and these bulking agents rely on patients getting adequate fluid intake in order to help bulk up and pull water into the stool. Switching gears from the bulking agents or fiber agents to the stool softeners, the stool softeners are indicated for the use in patients who shouldn't strain during defecation or who have a history of hard stools. So, interestingly enough, it's come to light in the last few years that there's really data lacking to support the efficacy of these agents as monotherapy. So their use as monotherapy has somewhat fallen out of favor, but you will still see them often combined with a stimulant laxative, which we'll talk about a little bit later in this discussion. Most of the stool softeners are essentially soaps and have lubricating properties, which help soften the stool, which causes an ease of passage during defecation. And a couple examples are listed for you here, such as docusate and mineral oil. As with fiber or bulking agents, the stool softeners assume that the patient is adequately hydrated. And you can imagine there's no added benefit in a patient with already soft stools, so we wouldn't use this class of agents for patients who are having constipation with softer stools. How they work is by lowering surface tension, which then allows the fecal mass to absorb the intestinal fluids. So again, that soap, if you will, acts sort of as a surface tension lubricant and allows the stool to absorb fluid. They typically act as with the fiber agents within about 12 to 24 hours, and they are safe for use in elderly patients. And it's noted that if you are giving a patient docusate, most of them will require doses equal to or in excess of 200 milligrams daily in order to see an optimal effect. I mentioned that the stool softeners may be combined in a product with a stimulant laxative, so let's talk about those stimulant laxatives. The stimulants are indicated for short-term prescription of constipation or to evacuate the colon as part of a bowel prep regimen for surgery. So you may see patients even just getting single doses of these the evening prior to a gastric or intestinal procedure. As I mentioned, they're often combined with stool softeners, and one of the more common ones that you see, and it is available over the counter, is Senna. And Senna acts to stimulate the colonic intramural nerve plexus, which then produces peristalsis. These have a slightly quicker onset in some cases than the other agents that we've discussed, but on the whole typically takes about a day for them to work. Bisacodyl is another stimulant laxative that you commonly see used and is also available over the counter. It also stimulates nerves in the intestinal mucosa, and it increases intestinal chloride secretion. So the overall result of this is a net fluid accumulation within the stool, and then that fluid accumulation allows for easier passage of the stool. Its onset is quicker, it's 6 to 10 hours, and that's why it's oftentimes recommended for patients to take it at bedtime, so that then they'll have their bowel movement the next day when they wake up. It is also available as a suppository form, which has a much quicker onset of action, about 15 minutes to an hour. So that's important for the patients to differentiate between as well. If they're using the suppository form, they should be ready for it to kick in within an hour, which is different from the oral tablets. The saline-based laxatives include magnesium laxatives and those containing sodium phosphate. And examples are mag citrate is probably the one that you see most commonly used. These as well are oftentimes used for bowel preparations. Magnesium citrate and sodium phosphate are usually reserved for bowel prep only for the simple fact that they can be pretty harsh, so most patients don't want to use these on a regular basis. However, they are very effective in evacuating the gastrointestinal tract for procedures. They act by an osmotic effect, and that effect draws water into the lumen of the small intestine and colon and promotes peristalsis. Again, we're assuming a well-hydrated patient that has water to draw into the lumen, so these wouldn't be good choices for a patient who you think may be dehydrated. One of the more common over-the-counter saline laxatives is milk of magnesia, and you can see that the onset of MOM, or milk of mag, is typically within about 4 hours of the dose, whereas the other two that we talked about already for bowel prep are typically within 1 hour. With the mag citrate and sodium phosphate, we tend to recommend avoid giving PO meds within an hour before the mag citrate and sodium phosphate, and the reason is those are just going to pass right through the intestine and not get absorbed well. So if you do have a patient doing a bowel prep for a procedure and they have bedtime medications, I would advise them to take them with their evening meal and then take the mag citrate and sodium phosphate at least a handful of hours after their medications so that they're getting absorption from their evening medications. One very important safety point for these products is they need to be used with caution or avoided even in renal failure patients. The magnesium and phosphate in the preparations can accumulate with repeated doses, and there actually has been some data to show that sodium phosphate bowel preps in renal failure patients are enough to tip them into hyperphosphatemia. So we try to avoid those in patients on dialysis. The hyperosmolar laxatives include those listed for you here, and you may be familiar with lactulose, glycerin, polyethylene glycol, and sorbitol. They too act as an osmotic effect, so the osmotic effect in the colon draws that fluid into the lumen, distends the bowel, and promotes peristalsis. The hyperosmolar laxatives are often used for bowel prep, and they can be somewhat harsh as well, resulting in stomach cramping and severe stools. They have a very rapid onset, which is why you'll oftentimes see them used on the inpatient side for patients who are going for procedures. So if you have to give a patient polyethylene glycol, it's recommended, again, per our previous discussion, that we don't give their oral scheduled medications within 1 hour of a planned administration, because those medications are likely to just pass right through the patient and not be absorbed. We're going to briefly touch on enemas used to treat constipation, and those available include the mineral oil and sodium phosphate enemas, as well as using a simple tap water enema for your patient. Enemas act to create a barrier between the feces and the colon wall, which then prevents colonic reabsorption of fecal fluid. To a lesser extent, these have a lubricant effect, especially the mineral oil, that eases passage of the feces through the intestine. One very important safety point is that Fleet's enemas are to be avoided in renal failure patients, again due to their high phosphorus load that can tip a renal failure patient hyperphosphatemic even with a single dose. And also, soap suds enemas are no longer recommended due to the risk of irritation or hemorrhagic colitis. So tell your patients if they've been using those, or if you're using them in practice, please realize that they're no longer recommended. We're going to shift gears now to the opposite end of the spectrum and talk about medications used to treat diarrhea. We're going to begin by talking about the opiate-opioid derivatives. I've listed a couple common ones for you here. You're probably all familiar with loperamide and perhaps also diphenoxylate atropine preparations. Tincture of opium used to be more widely used as an antidiarrheal, but it's not recommended anymore unless there's severe resistant cases. How these agents all work is they act on the GI smooth muscle to slow motility. And so a slower motility time or a slower stool transit time allows for more reabsorption of fluid from the stool back into the gut. So it's leading to a more formed solid stool. Another class of agents used to treat diarrhea are the adsorbent agents, and they act by binding bacteria and bacterial toxins within the GI tract. They do not have an effect on gastric motility, so they don't slow the gut down like previous agents that we've spoken about. With that, they're probably the safest to use if you're trying to control infectious diarrhea because they don't slow the gut down. However, it's always important to try to determine the source of diarrhea prior to picking an agent to control it. We're now going to switch our focus to agents that we use to treat gastroesophageal reflux disease, or GERD, and peptic ulcer disease. Prescribing a medication for GERD or peptic ulcer disease assumes that it's also in conjunction with non-pharmacologic interventions. So patients should be counseled to avoid foods or medications that lower the lower esophageal sphincter pressure, such as caffeine. They should also be counseled to avoid medications that delay gastric emptying, and we've talked about some of those already, but an example again are your anticholinergic agents as well as your opioid narcotics. Weight reduction and elevating the head of the bed, as well as many more suggestions that are out there, are all good counseling points, and teaching your patient that, again, this pill isn't the magic bullet. There's many lifestyle changes that you can partake of that will also help control your disease state. That being said, however, many of these patients will require pharmacologic therapy to treat their disease. And the American College of Gastroenterology has put out guidelines for the treatment of gastroesophageal reflux disease. And these guidelines state that acid suppression is the mainstay of GERD therapy. Antacids and over-the-counter acid suppressants are appropriate for initial self-management, and I think that's a great point since many of these, including proton pump inhibitors, are now available over the counter. It's important to assess what your patient has used and how they have used agents prior to coming to your office to seek treatment. And if there's persistent problems despite their over-the-counter use, that's when further workup is warranted. So when they present to you, if they've been using an over-the-counter agent regularly, that's when it may be appropriate to do some further digging and workup. According to the guidelines, the initial approach depends on the frequency of the patient's symptoms as well as the severity of symptoms. And they have two ways of approaching the step-down and step-up treatment algorithms. The step-down treatment starts the patient on a maximum prescription option, such as a therapeutic dose of a proton pump inhibitor. It's always appropriate as first-line therapy for patients with documented esophageal erosion, and it usually provides rapid symptom relief. However, if we did this with every patient, even the non-severe cases, we would potentially be over-treating patients and exposing them to high drug costs. So it's important to, again, base your initial treatment style on severity and frequency of symptoms. The essential opposite of the step-down treatment approach is the step-up treatment approach. The step-up approach might be more appropriate for patients with less frequent or less severe symptoms. If a patient has documented erosion, that would not be an appropriate candidate for this style of treatment. Patients with esophageal erosion should all be on full doses, full therapeutic doses of proton pump inhibitors. What the step-up treatment approach does for patients is start with a lower dose of an over-the-counter product or perhaps an H2 receptor antagonist versus a proton pump inhibitor. And what this does is avoid over-treating the patient, so we're not treating them with an agent that they don't need. And it also usually results in an initial lower drug cost, since most of these products are less expensive than the prescription products. There is a potential for undertreatment in these patients, however, especially if there's someone who's not likely to follow up with you if the initial treatment isn't working. And this may lead to a prolonged time until they have relief, or they may have persistent symptoms for a longer time. So again, I would recommend it more for patients with mild to moderate infrequent symptoms. I'm not going to go into a lot of detail about the antacids, but I'm just going to pull out a few key points that I think are good for you to remember. Typically, these are used for infrequent symptoms, so symptoms less than twice weekly, or patients who may be on maintenance therapy but have some breakthrough symptoms. Per the guidelines, their effectiveness is only about 20%, so you can see why they're not necessarily the appropriate class of agents to use in moderate to severe disease. Two things to point out about the content of most of the antacids: they're usually either aluminum-based or magnesium-based. And those that are aluminum-based can lead to constipation, where those who are magnesium-based can lead to diarrhea. So if you do have a patient that comes in and states that they're taking antacids and complains of constipation or diarrhea, assess which formulation they're taking, and that may be your answer to the problem. As we've already mentioned with some of the agents used to treat diarrhea and constipation, there is a potential for the accumulation of aluminum and magnesium in renal disease. So if you're taking care of an end-stage renal patient, it's important to make sure that they know not to take these agents without explicit direction from their provider. And finally, there's many drug interactions with antacids. We've already talked about in some of the anti-infective lectures chelation interactions, since many of these are divalent cations and can chelate medications, keeping them from being absorbed in the gut. And also, since we're altering the acidity of the gastric acidity, any acid labile drugs such as iron or itraconazole may have reduced absorption if a patient takes them with their antacid. We'll now shift gears to the histamine 2 receptor antagonists. They're also sometimes called the H2RAs or the H2 blockers. I've listed for you here ranitidine, famotidine, cimetidine, and nizatidine, and all of these act through reversible inhibition of the histamine 2 receptor on the parietal cell. And they are available over the counter and are often used by patients for intermittent symptom treatment. They are less effective than proton pump inhibitors in healing erosive esophagitis. Therefore, they are not the treatment of choice for that disease state. These agents are typically well tolerated. They do have some central nervous system side effects associated with them, including headache, dizziness, and confusion. The elderly patients and renally impaired patients are at the highest risk for these side effects, and that's why they all have dose adjustment recommendations for decreased renal function based on creatinine clearance. So if you have a patient with renal insufficiency, consult the prescribing information for the individual agent that you're prescribing to know the appropriate dose for their renal function. There are a few drug interactions, mostly with cimetidine, as listed for you, since cimetidine is a CYP450, 1A2, 2C9, 2D6, and 3A4 inhibitor. There's obvious drug interaction implications with its use, which is why it's sort of fallen out of favor and is often avoided when we can use ranitidine or famotidine in a patient. Another interaction with cimetidine is that it may also compete for tubular secretion in the kidney. So there's certain medications that are secreted in the kidney, and if cimetidine is given concurrently with one of those medications, you can have a decreased secretion and then increased levels of that drug. And as with the antacids, if there's any medication that requires an acidic pH for absorption, a patient in an H2 blocker is going to have a less acidic pH, and thus the absorption of those agents may be reduced. The newest class of medications, as well as the most expensive class of medications used to treat GERD, are the proton pump inhibitors, and I've listed them for you here. They act differently than the H2 blockers in that they irreversibly, whereas the H2 blockers were reversible, if you'll remember, but the PPIs irreversibly inhibit the final step in gastric acid secretion. They accumulate in the acidic compartment of the parietal cells, and the medication binds to the hydrogen potassium ATPase at the secretory surface of the gastric parietal cells. And what this does is inhibit both the basal and stimulated acid secretion. So basically, there's always a certain degree of acid suppression in these patients, and then around mealtime, when there's stimulated acid secretion, these medications rev it up a little bit. So it's inhibiting both the basal and stimulated secretion. The PPIs have been shown to be most effective agents for short-term management of GERD with erosive disease. And their best effect is when they're taken before meals, because then we can have that stimulated acid production also suppressed, since the meals can stimulate acid production in the gut. So if your patient is taking a PPI twice daily, instruct your patient to take their first dose before the morning meal and take the evening dose before supper rather than at bedtime. And that will get the maximal effect of suppressing that stimulated acid production. As a class, the PPIs have a longer duration of action than the H2 receptor antagonists. As I mentioned, they're also the most costly. They're quite well tolerated, with some of the side effects being headache and diarrhea isn't uncommon. I've seen that in several patients, and can often be managed by dose reducing the PPI dose. And also, due to some malabsorption issues, there's a potential for vitamin B12 deficiency with long-term use of these agents. So it's advisable, if you are going to have a patient, especially an elderly patient at risk for B12 deficiency, who's going to be on a PPI for a prolonged period of time, it's probably worth checking B12 levels. Promotility agents are typically not used as monotherapy for gastroesophageal reflux disease, but rather for adjunctive therapy. And these agents act to facilitate gastric emptying. So if you empty the gut quicker, there's less stimulated acid production and therefore some symptom relief from the GERD. The one that we talk about most or see most widely used is metoclopramide. And metoclopramide is a cholinomimetic and a dopamine antagonist as well. And those two properties allow for improved gastrointestinal motility, and it's all based on acetylcholine. So it increases acetylcholine release from the myenteric plexus, and that causes a contraction of the smooth muscle and causes that increased gastric motility, moving everything out. Just have a couple of pearls I'd like to share with you about metoclopramide. Due to its action on dopamine, it is contraindicated in Parkinson's disease patients and should be avoided in that population. It does require adjustment in renal dysfunction, so make sure to check your patient's renal function and creatinine clearance before prescribing this agent. Its adverse effect profile includes dizziness, fatigue, and hyperprolactinemia. One other thing that I want to mention is patients can get diarrhea from metoclopramide. Since it's a promotility agent, it's obvious that if we may be dosing a little too high, or if we're not properly adjusted for a renal failure patient, metoclopramide can actually induce diarrhea. And this is a good example of screening the medication profile prior to using another pharmacotherapy agent to treat diarrhea. If your patient is on metoclopramide and experiencing diarrhea, reduce the dose or stop the drug prior to giving them an agent to treat the diarrhea. We're now going to shift our focus from GERD to peptic ulcer disease, and very briefly just talking about some of the associated bullet points with gastric ulcer versus duodenal ulcer. Gastric ulcers are associated with H. pylori, NSAID use, and stress, and the epigastric pain typically worsens with eating. Whereas duodenal ulcers are 95% associated with H. pylori and also NSAID use, it's often epigastric pain which is relieved by eating. Since one of the risk factors for peptic ulcer disease is actually a medication or class of medication, the NSAIDs, I wanted to talk a little bit about NSAID-induced ulcers. The mechanism for NSAID-induced ulcers is due to direct mucosal damage, so the actual physical presence of the NSAID against the gastric mucosa, as well as cyclooxygenase 1 inhibition. Now, most of the NSAIDs are inhibitors of cyclooxygenase 1 and cyclooxygenase 2 in the arachidonic acid pathway. Cyclooxygenase 1 is actually protective to the gastric mucosa, so inhibiting this cyclooxygenase enzyme can lead to an increased risk for gastric bleeding. There's some other risk factors that are associated with NSAID-induced ulcer listed for you here: advanced age, history of previous ulcer, a higher NSAID dose and a longer course, using multiple NSAIDs at the same time, patients who are on steroids, which can decrease the healing rate of a gastric erosion, or patients on anticoagulants, which can obviously just make them more prone to bleed, as well as underlying cardiovascular rheumatologic diseases, relative increases with alcohol use as well. So patients who drink large amounts of alcohol have been associated with increased incidence of GI bleeding. Part of that could be due to hepatic issues and not producing clotting factors, but also directly caustic to the gastric tract. So the obvious first step in treating an NSAID-induced ulcer is to discontinue the NSAID, which you'd be surprised how many times patients have a misconception of what is and isn't an NSAID. So it's important to counsel them on their over-the-counter medications that they're using for pain or even for cough and cold, which may contain ibuprofen. So it's very important to sit down with the patients and tell them what exactly they need to discontinue. Then it's recommended to test for H. pylori and to treat if that test is positive. The proton pump inhibitors are the drug class of choice for healing and secondary prevention. Misoprostol has a similar efficacy, but it's poorly tolerated, and most of that is due to the diarrhea that patients experience. And unfortunately, even though they're very cost-effective therapy, the H2 receptor antagonists have been shown to be inferior to proton pump inhibitors or misoprostol in the healing or prevention of recurrence of these ulcers. I alluded to the treatment of H. pylori if it's positive by test, and the American College of Gastroenterology advises a 14-day course for treatment. They state that the 14-day course is preferred, even though their guidelines do state a range of 7 to 14 days. And typically you're going to give the patient a regimen that contains a proton pump inhibitor plus 2 antibiotics. And ones that are commonly used are amoxicillin a gram twice daily plus clarithromycin 500 milligrams twice daily, or using metronidazole if you have a patient who has a penicillin or macrolide allergy. So if they're allergic to penicillin, you would swap out the amoxicillin with metronidazole, or if they're allergic to the macrolide, you'd swap out the clarithromycin with the metronidazole. So 2 antibiotics plus a proton pump inhibitor. If your patient is not responding or still has a positive test, you can use quadruple therapy, where you would add in bismuth subsalicylate. And the quadruple therapy regimen typically consists of the bismuth, metronidazole, tetracycline, plus the proton pump inhibitor. There's references out there, including your text and some of the online readings, that provide additional regimens to use for patients. Quadruple therapy tends to be the most effective. However, oftentimes patients have a difficult time with quadruple therapy just from a compliance reasons, which is why oftentimes the 3-drug therapy is first line for most patients. The last gastrointestinal disorder that we're going to discuss in this lecture is irritable bowel syndrome, or IBS. So in irritable bowel syndrome, there's altered gut reactivity, and the patients typically have a hypersensitive gut with enhanced visceral perception and pain. And this results from a dysregulation of the brain-gut axis, and oftentimes is associated with high stress reactivity and altered modulation of the visceral afferent signals. And reading a little bit more about the detail of this disease, you can find that in the AGA medical position statement, which I've referenced for you below, and that's also available online. The pharmacotherapy is based on the nature and severity of the patient's symptoms, and it is important to realize that there is a psychosocial component. Many of these patients do have anxiety about their symptoms, so this may then potentiate worsening of symptoms. So we'll talk about a little bit of each of the ways that we can address and target symptom control. If patients are complaining of abdominal pain, you could consider an antispasmodic agent or a tricyclic antidepressant for its anticholinergic properties. If they're complaining of constipation, we can encourage them to increase their dietary fiber or use an oral fiber supplement agent. If they're complaining mostly as diarrhea as the major symptom, that's when you can use one of the antidiarrheals that we spoke about earlier in this lecture, and probably the most common and well tolerated is loperamide. In IBS, serotonin has been shown to be a player in the disease state, and serotonin is involved in regulating GI motility, sensitivity, and secretions. So focusing on this as a potential role for drug therapy, 5-HT or serotonin receptor agents have been developed and used to treat IBS. For patients who are more tipped towards the constipation side of IBS, tegaseride was an option for these patients, or it used to be under the brand name Zelnorm. Zelnorm acted as a 5-HT4 receptor partial agonist, which then enhanced motility throughout the GI tract. The dose was listed for you here, but unfortunately, due to an increased incidence of bowel ischemia, it's now only available in the U.S. under restricted access. So this wouldn't be something that would probably be prescribed in the primary care setting. Rather, it would probably be prescribed under the supervision or in correlation with a gastrointestinal specialist. For patients who have predominantly diarrhea symptoms, there's another 5-HT receptor agent on the market, and that's allosetron, or brand name Lotranex. It acts on the 5-HT3 receptor subtype as an antagonist. It returned to the market in 2002 after it had been pulled from the market, and it was pulled again due to bowel ischemia. So you can see that the agents that act on serotonin receptors aren't without risk. It's back on the market with restricted basis, and the restrictions right now are it's indicated only for women, and it's indicated for diarrhea refractory to all other prescriptive options, and it's only allowed to be prescribed by registered prescribers. So you have to go through an education program and sign up with a registry in order to prescribe this agent. Another medication available to treat chronic idiopathic constipation is lubiprostone, or brand name Amitiza. It acts differently than the medications that we've discussed thus far. It's a locally acting chloride channel inhibitor. So what this does is by inhibiting that chloride channel, it enhances a chloride-rich intestinal fluid secretion, and it does so without altering the serum potassium or sodium. And this chloride-rich intestinal fluid then increases motility and stool passage. So again, this has a slightly different mechanism of action of any of the other medications that we've talked about thus far. And due to its mechanism of action, you can see why it's used for the constipation side of IBS versus the diarrhea side. I alluded to the psychosocial aspect of IBS as well, which is why you'll oftentimes prescribe an antidepressant for these patients. And it's not indicated for all patients with IBS, but the use is based upon the principle that many of these patients often do have an anxiety component to the disease state. And this also, the antidepressants may have a centrally mediated or local effect on the gut that enhances the visceral and or motor activity of the gut. Of those out there, of the antidepressant classes out there, the tricyclic antidepressants as well as the selective serotonin reuptake inhibitors seem to have a centrally modulated pain-reducing effect as well. So that's why these may be good choices for your patients. Now that being said, if you have a patient with constipation, note that the TCAs are anticholinergic and may worsen the constipation. On the flip side, SSRIs sometimes have the adverse effect of diarrhea. So if you have a patient with severe diarrhea and you give them an SSRI and it seems to worsen rather than get better, it's probably the SSRI a side effect of it. But that's not to be said that that happens in all patients, but it's just a potential consideration when you're prescribing these medications in patients with irritable bowel syndrome. And I would like to thank you for your attention through the course of this discussion and ask that you please post any questions that you have about the lecture or any of the required reading materials or web-based materials in the Ask the Pharmacist link for this module. Thanks.